Hello, everyone. It's me, Andrew Farkas, and today we are going to do a spy review session. And the topic will be sedative hypnotics, muscle relaxants, and withdrawal syndromes. If you like structures, here are some structures. We've got Xanax on the top left, phenobarbital on the right, and cyclobenzaprine or Flexeril on the bottom left. Some of those will come up later. So, our goals today are that we are going to describe the clinical effects and withdrawal syndromes of benzodiazepines, barbiturates, and quote unquote muscle relaxants. We'll also review diagnosis and diagnostic pathways and treatment modalities for these conditions. First, we're starting out with benzodiazepines. We know and love these drugs. More often than not, our patients don't have enough benzodiazepines, but every now and then they have too much. So I guess we'll have to talk about that. So, benzodiazepines are GABA agonists. They affect the frequency of GABA channel opening, which differs from barbiturates, which affect the duration. A benzodiazepine molecule cannot open a GABA channel without GABA present. So this serves as almost like a self-limiting factor on their toxicity because your brain, has an equilibrium, and if there's too much inhibition going on, it's not going to be sending GABA into the synapses. So patients who take an overdose on a benzodiazepine typically do not have as severe consequences as certain other CNS depressants because of that biochemical fact. So, benzodiazepines, as a result, have a high toxic to therapeutic ratio, and death from these drugs is very rare unless they are combined with other CNS depressants. That being said, if you have someone who has taken an opioid overdose, even a very small amount of a benzodiazepine, if present, can significantly enhance the toxicity of something like an opioid. So, in combination with other things, they can be very dangerous, and they're implicated in a lot of deaths, sort of as a guilt by association type thing. Like they almost always, only in combination with that. But um, on their own, not very dangerous. My favorite description of the benzodiazepine toxidrome that I ever heard was a benzo overdose is quote unquote a coma with normal vital signs. Onset can vary depending on the drug. Some are faster, like alprazolam or Xanax, and others are slower, like chlorodiazepoxide, also known as Librium. But the time of onset is typically going to be between 30 and 120 minutes when taken orally. And this constellation of symptoms is just going to keep coming up for the whole rest of the lecture because with a few small variations, they pretty much all do this: lethargy, ataxia, slurred speech, confusion, coma, respiratory depression, hyporeflexia. The duration and half-life will vary by the agent. And the complications are more likely to occur with the newer and faster acting agents, or in the case of IV injection. Diagnosis is going to be clinical and principally based on the history. Specific drug levels are rarely going to be obtained in a clinically useful time frame. In terms of the urine drug screen, it tends to do a better job picking up the older agents such as lorazepam or diazepam, and does a poorer job of picking up the newer agents such as alprazolam, just because they're structurally different, just enough that it can throw off an antibody driven assay such as EMIT or ELISA. In terms of ancillary tests to do, this largely depends on the clinical scenario. If you suspect aspiration, obviously you're going to want to add a chest X-ray, but fairly typical tests that you might want to get are a blood gas or a glucose. I would also consider getting Chemistries, just because you don't know if someone's been, down for a while, if they may have an AKI or an electrolyte abnormality or something along those lines. In terms of management, this is another theme that's just going to come up over and over again throughout this lecture, which is it's mostly supportive care. We want to monitor the pulse oximetry of these patients and protect their airway if needed, if they do have respiratory depression. It doesn't happen often, but it can happen. The mechanism that you're going to see for hypotension is similar to most CNS depressants. Benzodiazepines don't appear to have significant direct cardiac effects, but any CNS depressant can decrease your sympathetic outflow. So that means that you're going to be excreting less, norepinephrine and so forth from your adrenal glands just when your CNS is in a depressed state. So that's the main driver of hypotension, and that's the sort of thing that tends to be very treatable. Usually it's going to respond to fluids. I don't think I've ever had to recommend pressors for a benzodiazepine single agent overdose. The antidote, of course, is flumazenil. It's controversial. Some shops are much more pro flumazenil than others. Some places never give it, and other places it's more conditional. I think I fall into the conditional category. I wouldn't say that I never give it, but I don't routinely recommend it. It's something that has some significant downsides. The most, I think, well-known of those is that it can precipitate withdrawal, including seizures in someone who is habituated to benzodiazepines. Another problem with giving flumazenil is that you could end up in a situation where if someone has taken a polysubstance overdose, you might unmask an excitatory overdose that the patient had conveniently self-treated by also taking a benzodiazepine. And if you give flumazenil and you end up with an agitated patient, now you've kind of lost our favorite means of controlling agitation in tox patients, which is, of course, benzodiazepines. So it's not without downsides to give it. That being said, there are some situations where it can be helpful. One of those is if you have a strong suspicion, but you're not entirely sure that a comatose patient is under the effects of a benzodiazepine overdose. If you give a little bit of flumazenil as a diagnostic maneuver and they wake up and they tell you, oh yes, I did take a bunch of lorazepam today, then you might spare yourself a workup, including like a CT head and other things that you might have felt compelled to do. Because of flumazenil is only going to reverse a benzodiazepine overdose. It's not going to reverse anything else. So it's a reasonable diagnostic maneuver. And then in some cases, maybe it can help you stave off an intubation. That's possible. The downside, though, is that because it doesn't last as long as a benzodiazepine overdose typically lasts, you face the possibility of having to redose it, and it's not going to net decrease the amount of time someone spends in a hospital in most circumstances. But if you are going to give it, you're going to start with 0.1 to 0.2 milligrams and be prepared for it to last an hour or two. In a benzodiazepine overdose, there's no role for enhanced elimination, such as dialysis, and a limited role for activated charcoal. In many cases, it's probably just not worth messing around with that because these don't tend to be very dangerous overdoses. More dangerous overdose would be a barbiturate overdose. So, barbiturates are also GABA A agonists, and they also cause CNS depression. Where they vary compared with benzodiazepines is that they affect the duration of GABA channel opening, and they are capable of opening a GABA channel all by themselves. So that's why you don't see the same ceiling effect that you see with the benzodiazepine overdose, where you really kind of hit this point where they don't get any more comatose than they are, and they are still breathing. Contrast that with barbiturates, where you can get such severe CNS depression, that it can mimic brain death. So much more dangerous than a benzodiazepine. They also do appear to have some direct cardiac effects, so they're probably going to be more likely to cause hypotension. They have a wide range in terms of onset and duration of action. There are ultra short all the way up to long acting barbiturates, so they vary significantly. And the typical toxic dose is going to be 5 to 10 times the therapeutic dose. Presentations already mentioned this, but benzodiazepines similar to benzodiazepines, but more so. And the sky's the limit. You could have a brain death mimic situation. One finding that's also reported is skin bullae, which is nonspecific but may be present. Just as with benzodiazepines, the diagnosis is going to be clinical and based on a history of exposure or ingestion combined with just general clinical suspicion. You can get specific drug levels, and these can be somewhat helpful because if someone has a very high very high barbiturate level, you might anticipate prolonged coma, perhaps lasting days. This can be very important because these patients are the sort of patients who people try to harvest organs from. So it's important to protect them from organ harvesting because people will falsely believe them to be brain dead. So that's where a level actually can have some utility. And the urine drug screen performs better for barbiturates than it does for benzodiazepines, both in terms of sensitivity and specificity. In terms of ancillary testing, that's going to be similar. You might consider basic labs. You might consider a chest X-ray if you're concerned about aspiration, and blood gas to kind of assess their respiratory situation in a little more detail. Management, just like before, supportive care, pulse oximetry, maybe intubation, more likely intubation than in a benzodiazepine overdose. There is no antidote for barbiturates. Flumazenil does not work on them. Activated charcoal is probably appropriate given the more severe nature of a barbiturate overdose. And you could also consider multi-dose activated charcoal, aka gut dialysis, to try to remove a barbiturate from someone's system by giving it every 6 hours and trying to interfere with that enterohepatic recirculation. There is also the option specifically for phenobarbital, not so much for the other barbiturates, that you could pursue urinary alkalinization. It is hypothetically something that can be enhanced in terms of elimination by that. I have to say that in terms of the cases I've seen, my feeling has generally been if you're really getting down that road, I probably would just proceed with dialysis. It would have to be a pretty kind of very weirdly in between patient of, being sick enough to consider it, but not too sick to want to do dialysis, where I would consider doing urinary alkalinization. I suppose it's possible, but I haven't seen a patient yet where I really felt excited about doing it. Cases where you might want to pursue dialysis would include severe toxicity and specifically refractory hypotension. Next, we're going to cover some other miscellaneous sedatives. Buspirone, brand name Buspar. I don't respect it, and neither should you. I don't think I've ever seen a sick buspirone overdose in my life. It may cause some nausea or vomiting, so I don't know, maybe get them some ondansetron to treat that. There is no specific testing, and it's purely symptomatic care. It has never killed anyone, which honestly is a credit to the drug manufacturers. Good for you, you made a safe drug. Z drugs. This is basically like a benzo, but not a benzo. These are your sleepers. They are known as more commonly as like the brand names would be Ambien or Lunesta. But yeah, zolpidem, zopiclone, and S-zopiclone are them. We call them Z drugs. They function chemically very similarly to benzodiazepines. However, they have a different chemical structure and they are less potent. Onset typically is within 30 minutes, and the half-life is anywhere between 1 and 7 hours. Just like with benzodiazepines, they are usually only implicated in death when combined with other CNS depressants and, in particular, opioids. They are also implicated in, or so they're also reversible with flumazenil, just as with benzodiazepines. There is not going to be a great way to detect these because their structural dissimilarity with benzodiazepines means that they are probably not going to trip the benzodiazepine urine drug screen, even though they function basically exactly the same way. So, just like with almost every other drug in this lecture, it's going to be a clinical diagnosis based on the history. Um, there are a number of deaths implicated with these, but once again, it's almost always in combination with other things. So by themselves, these are not particularly dangerous drugs. Next up, we're going to talk about the quote-unquote skeletal muscle relaxers. It's a little bit of a misnomer because they don't really act directly in any case on the neuromuscular junction or the muscle itself to induce muscle relaxation. They are CNS depressants, and it's true that you may have less muscle tone if your CNS is generally depressed. But as I was taught it, the only true muscle relaxants are drugs we use to intubate people with, like rocuronium or succinylcholine, or you could consider um, the reversal drug for malignant hyperthermia, dantrolene, to be a true muscle relaxant. These are really just downers. And they are not the most effective drugs in the world. They tend to struggle to defeat a placebo if you're trying to talk about whether they actually treat back pain or not. So I have a fair amount of skepticism regarding the quote-unquote skeletal muscle relaxers as drugs, but they're out there because back pain, muscle spasms, they're pretty common. And as a clinician, I can say, well, I don't think these are the greatest things in the world. I'd much rather give someone a prescription for a skeletal muscle relaxant than an opioid most times because as much as they may not be terribly effective, opioids are not effective for long-term pain in many cases either, and they happen to be a whole lot more dangerous. So, you take the good and the bad, I suppose. So, generally speaking, it's the same thing. Stupor, ataxia, slurred speech, maybe a coma. If you, in certain circumstances, they have a couple of quirks where they may act a little bit differently, and we'll cover those soon. In most cases, these sorts of drugs are readily detectable on a comprehensive urine drug screen, like a GCMS, but they are not usually something that you're going to be able to quantify, at least not in a clinically useful time frame. So, once again, diagnosis is going to be, you guessed it, clinical and based on the history. Baclofen is, in my opinion, the worst actor of all of the skeletal muscle relaxants. Unlike our friends benzodiazepines and barbiturates, it is a GABA B agonist, and that's important. GABA B is not a chloride channel like GABA A. GABA B is a G protein coupled receptor that has inhibitory downstream effects in a neuron. One of the catches with GABA B is that it's also expressed on the presynaptic terminal. And that means that while you can most often see CNS depression with a baclofen overdose, sometimes the presynaptic effect wins out. So when you have a presynaptic inhibitory effect on an inhibitory synapse, that's like a double negative. So presynaptic inhibition in an inhibitory synapse is tantamount to excitation. And that's why baclofen can cause weird presentations that don't seem to make sense. You might get CNS depression to the extent even that, once again, you have a brain death mimic, just like with barbiturates. But you also might see increased muscle tone and agitation and seizure-like activity, or even more frustratingly, a patient that whipsaws back and forth between the two of those things. So you're really chasing your tail, trying to come up with a means of managing them. It does have significant abuse potential, and we'll cover the withdrawal later in the withdrawal portion of this talk. So when someone ingests baclofen, you're generally going to see CNS depression within 30 to 120 minutes of the ingestion, which is pretty familiar with all the other CNS depressants that we've been talking about. Bradycardia is fairly common, and you may see respiratory depression to the extent that the patient needs to be intubated. The toxic effects of a baclofen overdose can last 12 to 48 hours, so it can be quite prolonged. Guess what? It's a clinical diagnosis yet again. You're not going to obtain blood levels in a clinically useful time frame. And it's pretty much straight supportive care. There's no reversal agent, flumazenil, etc. does not work on this. Dialysis, however, may enhance elimination. Managing these can be really challenging. A lot of the times you're going to have to intubate them for their CNS depression, but then also have to sedate them for their periods of excitation. So if I was managing one of these, I would, have someone on some basal sedation for being intubated, but be pretty aggressive with PRN medications. And once again, we're pretty much going to use benzos here for the most part. So something like a PRN midazolam or Versed to control bouts of agitation that may occur. And these can be kind of a long ride and kind of a rough ride when you're trying to manage them. All right, next up is carisoprodol and meprobamate. Carisoprodol is a dying drug, and meprobamate, I believe, to be more or less extinct. I don't think I've ever encountered a patient who was on meprobamate. Meprobamate was popular in like the 1960s. It was your classic quote unquote mama's little helper, a drug that was used to tranquilize housewives in the glorious golden age of medicine. Carisoprodol is basically a prodrug of meprobamate, and these days it's used, fortunately, less and less as a quote-unquote muscle relaxant. I will say that I saw this a fair amount when I was in training, and it was more commonly prescribed where I trained, which was in Pittsburgh. And I've seen less and less of it as time has gone on, and I consider that to be a good thing because it's a pain in the butt. So carisoprodol gives you this weird presentation where in general you get CNS depression just like all the others. You may see hyporeflexia and coma and stupor and possibly respiratory depression, but then you also can see weird myoclonus and a spastic encephalopathy with hyperreflexia, because by some uncertain mechanism, it does that. And these effects, I think, are why it rightfully has gone extinct, or nearly gone extinct as a drug. You could reverse it with flumazenil, but I wouldn't do that, because you might see this agitation and hyperreflexia, and you might want to give them some benzodiazepine similar to baclofen, or you might have a bout of agitation. You might want to sedate them. So I would definitely not treat someone with flumazenil, even though it might technically reverse their sedation. But in theory, you could. And once again, this is not a drug that can be eliminated via dialysis or other enhanced elimination strategies. This is pure supportive care and waiting it out. And an overdose of this can last a day or two, or they can be really out of it. Cyclobenzaprine. Can you spot the difference? So the drug on the left is cyclobenzaprine, brand name Flexeril, and the drug on the right is amitriptyline. So cyclobenzaprine is just one double bond away from being amitriptyline. And it was, in fact, a failed tricyclic antidepressant. They made it and they put it through trials and it didn't work. It just made people kind of sleepy. So they changed course and said, never mind, it's not an antidepressant, it's a muscle relaxer. This is helpful for trying to remember what it does because if you know the mechanisms of action of a tricyclic, then you know most of the mechanisms of action of cyclobenzaprine. So the quote unquote therapeutic mechanism of cyclobenzaprine is not that it's an SNRI like a TCA. As I said before, it's not a great antidepressant, but like TCAs, it has antihistamine effects. So as a centrally distributed antihistamine, it's going to make you sleepy just like diphenhydramine or Benadryl. So that's the mechanism by which it sedates you and causes the muscle relaxation. And it also has some other effects that you might see in a TCA, very specifically antimuscarinic effects. So you're going to get your classic anticholinergic delirium with your blank as a blank, right? So you're mad as a hatter, red as a beet, dry as a bone, all of those things. Anticholinergic delirium is common with cyclobenzaprine. What are you going to do about that? Well, you can give them physostigmine. I think that's reasonable. You just have to kind of watch out for seizures. In my personal practice, giving physostigmine, I never give it until I've also given someone a benzodiazepine to treat their agitation and also just to ward away possible seizures if I'm considering giving physostigmine. So that's just something to watch out for. Fortunately, compared to TCAs, it's a lot less cardiotoxic. So death is significantly less likely with a cyclobenzaprine overdose than with an amitriptyline overdose. It could still happen, but yeah, fortunately, that one double bond worth of difference is enough that you're much less likely to get some of the more problematic effects of a TCA. So that's a good thing. This is basically going to be the same supportive care that we've been doing for everything else. Intubate for respiratory depression, keep them hydrated, correct electrolyte imbalances, all that good stuff. There is no way to enhance or accelerate the elimination of cyclobenzaprine from the body, so you pretty much just have to wait it out. Orphenadrine. This is another thing that's like another thing. So orphenadrine is on the left, and as you can see, it is but one methyl group different than the drug on the right, which is diphenhydramine, aka Benadryl. So just like, actually not just like, cyclobenzaprine is a safer, albeit less effective TCA, orphenadrine is a more dangerous diphenhydramine. So this one actually can be kind of nasty. It can make you antimuscarinic, just like TCAs and just like diphenhydramine and just like cyclobenzaprine, but with a kicker of status epilepticus and cardiac arrest. So not great. I don't think anyone should prescribe this drug. Personally, I've never prescribed it. I mean, goodness, maybe there's someone out there that it helps, but yikes. So you can see delayed absorption due to the antimuscarinic effects, slowing gut motility. Supportive care is once again the order of the day. If you see some of the seizure activity, you're obviously going to want to treat that accordingly. I would start with benzodiazepines, which are, of course, our first line. And if you see refractory kind of status epilepticus, excuse me, then I would proceed with phenobarbital or something similar to that. And there's no enhanced elimination. Because orphenadrine is associated with tachydysrhythmias, I personally would not give physostigmine, kind of in the same vein of not wanting to give it for TCAs. Once again, could it help in theory? Yes. Would I do it? I would not do it. I would not give Pfizer to an norepinephrine overdose. Fortunately, this is probably one of the lesser prescribed quote unquote muscle relaxants, so don't see a lot of it. But if I did, I would be kind of concerned about it because it definitely can kill people. Tizanidine. The easiest way to think of tizanidine is as clonidine except shorter acting. So in this case, the CNS depression is coming from alpha 2 agonism. Alpha 2 is like the negative thermostat of your adrenergic system. It's going to just generally decrease your sympathetic outflow directly. And when you do that, you get CNS depression and coma, and in particular, bradycardia, once again, just like a clonidine overdose. The hypotension you see here can be significant, but it's going to be very treatable, right? Because you're not acting directly on, beta 1, beta 2 receptors on someone's heart, you're not going to get like a direct cardiotoxic effect. You're mostly just suppressing your circulating catecholamines. So if you want to fix that, just give them back their catecholamines and you're good. So I would give a norepi drip if someone did not respond to pressors. And then I would also, give IV fluid. Sorry, can we stop and go back? I would start a norepinephrine drip if someone did not respond to fluids, but most of the time fluids are probably going to be enough. And just like most of these other drugs, there is no antidote and there is no enhanced elimination strategy. Because it's shorter acting than clonidine, I perceive it as being less dangerous, and there's literature to back that up. People have survived overdoses of like 60 milligrams, which would be like 30 times the like a 2 milligram like typical dose, just with a coma, but no other kind of major ill effects. So this is not terribly dangerous, and once again, that's a good thing. Methocarbamol and metaxalone. No one knows very much about these drugs, but they're out there, so I thought I would at least mention it. They're probably GABA A agonists, maybe. We're not really sure. They cause CNS depression, like pretty much most of these other drugs, and they don't seem particularly dangerous. I struggled to find a case report of a fatality from these. If someone took a large overdose, I still would send them in just because, they might have CNS depression and need some good old-fashioned supportive care. But these are not scary in the way that like an orphanetrin overdose would be, potentially concerning. The last part of this lecture is we're going to cover some withdrawals. Some of these drugs cause withdrawal, some of them not really, and some of them we're not really sure because they're obscure. But in general, like treat light, so if they're, withdrawing from something, give them that back, at a nice stable dose. It's a clinical diagnosis, and that could be challenging because, particular with some of these drugs, you're going to have trouble differentiating, is this withdrawal or is it like a stimulant overdose, right? Because they can look kind of similar depending on the situation. And it's going to be hard to quantify a lot of the drugs to kind of like determine, if you have someone who's on the benzodiazepine, right, they might test positive for that in your urine for like a couple of days after they use it. So it's not like you can go and get an alprazolam level and be like, oh, they have a really low alprazolam level. Maybe they're in withdrawal. You're going to have a challenging clinical diagnosis. So the worst withdrawal that you can see is going to be baclofen of this group, in my opinion. What you would also see similar to it, if you've ever heard of Phenibut, the nootropic supplement, it shares a mechanism with baclofen, and its withdrawal should be treated in the same manner as baclofen, as an aside. So you would expect to see someone withdrawing from a CNS depression to demonstrate excitation or seizures, and you'd be right. But just like I mentioned before, how the presynaptic effects of baclofen can cause sort of a paradoxical opposite effect in overdose, you can also see that in withdrawal. So you can have a patient who is in an excitatory delirium, or you can have a patient who is exhibiting CNS depression, or a patient who's going back and forth between the two. And what makes things even more frustrating is you could have someone who initially comes in as a baclofen overdose, and then they seem to be getting better, and then they seem to get worse because their overdose resolves, and then they go into withdrawal. And since you can't get baclofen levels, it can be really difficult to know. So, in these patients who I see who come in with a baclofen overdose, if they're having really prolonged agitation, particularly around day like 3-ish, that's where I might start to think maybe we should actually give them some baclofen back. Although you're kind of flying blind. You don't really know for sure how much is in their system. So it's a diagnostic challenge. And it's a treatment challenge as well. If I suspected someone was going through baclofen withdrawal, depending on how severe it was, I would put them on 10 to 20 milligrams TID. And you could also supplement with benzos as well to try to keep things under control. Benzodiazepine withdrawal. I would describe this as alcohol withdrawal, but less severe, less dangerous. When you withdraw from alcohol, alcohol has 3 receptor effects. It is a GABA A agonist, it's a NMDA antagonist, and it is a glycine agonist. So you've got 3 receptor effects to potentially withdraw from. Whereas benzos being relatively pure GABA A agonists, you're not going to have as many receptors that are in on the action. So I would describe benzodiazepine withdrawal as a less severe alcohol withdrawal. You're going to still see potential for seizures, but you're less likely to see the really traumatic autonomic effects like tachycardia or hypertension and that sort of thing. One of the annoying things about benzodiazepine withdrawal, and specifically about alprazolam withdrawal, is that the only thing that seems to treat it is alprazolam. It's tempting when you have someone withdrawing from something so short acting as alprazolam is to give them something longer acting because you're like, oh, this will be easier to taper them off, like maybe Librium or chlordiazepoxide, right? But you can't really do, or at least you could try, but it doesn't seem to work. So when people have alprazolam withdrawal, unfortunately, you're just stuck doing this really kind of annoying taper of alprazolam, just trying to bring them down gradually because that seems to be the safest way to do it. And they're going to be in withdrawal for a few days, just like with alcohol withdrawal. So that's the time frame in which you're going to have to try to get them off of it. And then I have seen a couple of patients ever in Tizanidine withdrawal. It's not common because it's pretty unusual that people get hooked on Tizanidine, but it can happen. And they get so tachycardic. So they are agitated, they're anxious, like diaphoretic, and then their heart rate's getting like 140 or 150 if they're in really bad Tizanidine withdrawal. I would probably attempt to treat it with clonidine because it is longer acting, and I would hope that would be an easier drug to kind of taper them off. Of course, there are these news reports now of people getting medetomidine withdrawal. With the contaminated fentanyl supply, in Philadelphia. I haven't seen anything outside of news reports. I think this will be kind of fodder for our conferences next year, and there'll probably be some medetomidine withdrawal abstracts out there. But maybe we'll start to see something similar with that. So something to anticipate, because it can be pretty severe when it does happen. Just doesn't happen a lot. But now that we've got this contaminated drug supply, who knows? So. Once again, I would treat it with escalating doses of etomidine, with clonidine. If it's really bad, maybe a Precedex drip or dexmedetomidine drip might be the way to go. So this concludes our talk on sedatives and their withdrawals. I hope it was helpful, and feel free to email me or whatever if you have any questions. Thank you.